last presenter of this session is William DuMouchel, who's from Oracle Health Solutions. Who's going to be talking about adverse drug reaction associations and some Bayesian safety modeling. Get your prior probabilities on.
Thank you. I'm happy to be here. I'm going to talk a little bit in slightly different mode, more oriented towards methodology and the analysis of these big data. But what I'm hoping to do is to demystify a little bit the notion of Bayesian methodology, which typically gets mentioned in the newspaper as some mysterious new magical method. It's actually based on very common sense approach. The examples, all I'm going to be doing are going to be talking about analysis of drug safety data. A lot of our work has been developed in collaboration with the FDA and other pharma companies. One of the issues, there are spontaneous reports of adverse events with drugs that are routed to the FDA and to other regulators. There's also adverse events when you have a clinical study. There's longitudinal healthcare data that monster databases are being created, and then you can try to look for associations between drugs and adverse outcomes. Until the last decade or so, statisticians were reluctant to apply formal analysis models to these types of data. It had been more common to just send the adverse event reports to medical reviewers, and they would kind of take it as anecdotes to try to learn things, but it wasn't really treated as a database to be analyzed. The obvious benefit to having a better safety data model, so why were statisticians reluctant to work on this? Statisticians perhaps have a reputation, or had a reputation decades ago, of being a little too fussy, and they didn't want to look at crappy data. Whereas it probably is better to say a good statistician should try to make the most use of, and statisticians are needed more for noisy data than for non-noisy data. The characteristics of such data that made statisticians leery are, first of all, there's a lot of small sample sizes because, thank goodness they're running a lot of safety problems with drugs. I mean, most drugs don't cause a heart attack in most patients, so the small sample sizes are often difficult, especially with clinical data. And then there's the multiplicity issue. There's so many potential safety issues, even what to focus on to do a statistical analysis is a little difficult. Statistical theory often requires a pre-specification of significance thresholds and so forth, and so to just notice that something unusual is happening it makes it hard to decide even how significant things are. I'm going to talk first about one type of data called the spontaneous reports. Typically, there's a big collection of reports. I think the FDA has a database now of about 7 million of them, in which patients are reported that they're taking these 3 drugs and they had these 5 bad things happen to them. And there's 7 million of those reports lined up. And in general, if you kind of look at across it, there's perhaps 5,000 drugs if you just talk about the common name of the drug. And maybe there's the adverse events are classified into a vocabulary called MEDRA that has perhaps 10,000 different events because it's kind of fine-grained. So right away you'd have 50 million drug event combinations just by multiplying those possibilities together. So clearly you're going to get thousands of, quote, significant results by chance alone. Findings would require a follow-up here. And typically these are not research quality data. The adverse event reports can vary from year to year and so forth. So the causal notion, you're really looking just for suspicious signals. Typically, the first approach towards analyzing data like this would be to just, for each of these 50 million drug event combinations, to create a 2-by-2 table where you talk about how many reports had this particular drug mentioned, how many did not, how many reports had that particular event mentioned, how many did not. You've got a sort of ABCD, your standard first course in statistics, analyzing a 2-by-2 table. And then you could just take a ratio of the actual observed count in that upper left cell together with some kind of expected count based on the independence notion. So like the row total times the column total over the grand total is your typical expected count. So taking that n divided by e, the problem is, although that's an intuitive thing that seems nice, if n divided by e is 20, it means there's 20 times as many reports as you might expect by chance. But if n is 1 and e is 0.01, that value of 100 is pretty suspicious, as probably a lot of those are going to show up without having any kind of causal notion. The crucial Bayesian insight is that you don't look at each of those zillions of tables in isolation, but you consider the ensemble of all these drug event combinations. These millions of 2x2 tables, there is a lot of data actually, it's just that they're all about slightly different problems. They're slightly different drugs, slightly different events. Combining structurally similar problems allows us to detect patterns across the different drug event combinations, so that the analysis of each combination can borrow strength from the rest of the data. So broadening a problem to include a whole class of similar problems is often called a hierarchical approach. And these Bayesian hierarchical models use the drug event combinations as a framework for estimating the distribution of the disproportional effects. One very simple statistical model is called the gamma Poisson shrinker, or the gamma Poisson hierarchical model, in which each count is assumed to have a Poisson distribution whose mean is some multiple of the expected count. And those multiples, if they are 1, of course, that kind of means things are just chance alone. But that ratio of n divided by e could itself have a prior distribution, which is often used a gamma distribution as a convenient one. And when you do that, you can use that in order to get a better estimate of the ratio than just the simply dividing n divided by e. The actual estimates of lambda that come out of this standard Bayesian technology will be more stable than that. The Bayesian paradigm is that you have individual disproportionality. They're kind of weighted a bit towards all of the other drug event combinations. So that's the notion of combining all of these problems in one place. You're making the multiplicities work for you rather than against you, because you're using the pattern of the other ratios of n over e to improve the estimate of any particular one that you're looking at. Now, since the vast majority of drugs don't cause any particular event, in general, what that really means is that you're modifying the values of n divided by e to be a little closer to 1 than the raw value. And so that's why the idea of shrinking is there. The idea is that the ratio is shrunk towards 1, even if it happens to be rather large and bigger than 1. Like we talked about the n divided, 1 divided by 0.01 is 100. The pattern across all of the drug event combinations is called the prior distribution, and you combine those results to get a posterior estimate, or a better estimate than just that raw ratio. That's sometimes called the shrinkage estimate. This is an example. You don't have to read the fine print here, but each of these lines, each of these rows in these graph is one particular drug combined with one particular event. The rare combinations are put up there at the top. Typically, the ends in those top 10 have counts of only 1 or 2, and the little plus sign is the actual ratio of n divided by e, which is, and the ones that I chose here are like 1,000 or even 3,000, but they might have been an n of 2 and a value of 0.001. And the circles are the Bayesian estimates that come out of applying the prior distribution that gets estimated. And you see that those numbers, because the sample size is so small, that ratio is discounted so much that the actual estimate, a better estimate than the raw estimate of 1,000 might only be 2 or something like that. In the middle group of our drugs and events that have shown up in the database maybe 20, 30, 40 times, in this particular case there's not much difference between the raw and the estimated, the Bayesian estimate, but they're sort of shrunk just a little bit. And then there's a few cases in the database that have occurred hundreds and hundreds of times, and in that case there's really no difference, and the Bayesian estimate is just about the same as the raw estimate. So that's an approach for that particular kind of data, but that same idea can be used for many other kinds of data, and I just want to run through a few other sorts of things. Here, this is an example of the use of these estimates to look at relationships between cardiac issues and NSAIDs in the database back a few years ago. Back around 2003 or so, a drug called Vioxx was viewed as a kind of a surprise in that it was very widely prescribed and yet seemed to have a lot of medical problems with cardiac issues. On the left-hand side, the rofecoxib is the Vioxx, which shows even in early 2003 that it was definitely worse for MI than all these other NSAIDs. On the right-hand side, we see that even minor events like blood pressure increased with the 3 COX-2 inhibitors. The rofecoxib was definitely showing to be a much bigger estimate, even in the year 2000, which was several years before the Vioxx scandal came to light. Another way you can do this sort of analysis would be to detect changes. Here, and rather than talk about combining different drug event combinations to get a better a comparison of observed versus expected, the issue is that could you detect a change in frequency if you're monitoring these spontaneous reports over time. In this case, the expected count doesn't come from other drugs and other events, but it comes from a kind of a projection of the past months to the next 2 months in advance. And so the line is the projection based on fitting a time series model. The reason why it wiggles back and forth is because there's a seasonality component, and a lot of adverse events get reported more in one season than another. And then and these are just raw counts, and and the idea is, can you detect a big change very quickly within the first month or two, and without having too many false positives, because you're still talking about the fact that monitoring for a drug, there might be 500 different adverse events that are showing up over the course of that drug's history, and you don't want to have too many false positives when you're looking at all of these combinations, and this is proven to work fairly well. There are various biases in this kind of approach to just using a 2x2 table. A 2x2 table is your very simplest kind of analysis. You might wonder how come we restricted ourselves and aren't using more powerful tools. One is masking. If you just compare reports that have a given single drug to all the other reports with other drugs, well, a lot of the other drugs that will also be strong, many of the other drugs might be a strong causal connection to that adverse event, and yet they've got lumped in as the control group. So you would imagine it would be better to kind of not include other known problem drugs into the control group. So it's better to have a simultaneous estimate across all drugs that have high associations. Confounding is another issue that often shows up that would be bias these 2x2 tables. If you have a situation where patients, let's say with diabetes or with AIDS, they take a lot of drugs, and so if a diabetes patient, if there's some drugs that actually do cause a lot of adverse events, with diabetes patients, well then even something, an innocuous drug like insulin, might show up because the same patients that are taking insulin are taking these other more dangerous drugs. So that there's a sort of an innocent bystander effect where a safe drug is taken by the patients, same patients that take other drugs, and that can result in transference of these methods. So the typical approach towards isolating these common multiple factors is a regression. And regression methods, you can use logistic regression or other types of regression. And there are ways to, again, use Bayesian shrinkage methods with regression predictors in order to both isolate out the polypharmacy problem, where you have multiple drugs taken by the same patient, as well as to get rid of these inappropriate comparator drugs. This is a graph of the predictive power, the positive predictive value for methods that do or just use the 2x2 table. The simplest method for using the 2x2 table is the green line, which has much lower predictive power than the red line, which is the method that's using the regression-styled methodology with the Bayesian shrinkage. There are, besides these adverse event reports, there are things like controlled clinical trials, there's healthcare records, and there's plenty of other types of data which will have different kind of models, but these Bayesian shrinkage models are useful there too. For example, you could have even a set of clinical trials in which you're interested in worries about dehydration and other things that might cause nephrotic issues. Here's 10 different MEDRA preferred terms that all are somewhat medically related, and so the question is, should you analyze those 10 terms completely separately, or should you lump them all and just call it one term if any of them are present? And if you'd like to get 10 separate estimates to make it plain as to what problems are showing up in this trial, but the question is also, do they have similar responses to various predictor variables? So here again, you're talking about you have 10 separate scientific problems, but they have a lot in common. They probably have certain common medical causal issues because they are related to the same body systems, and the question of how much they should be kind of merged together or not can be tackled by these Bayesian shrinkage methods. So in one particular study that we were working on, you would look and see whether the difference between the treatment and control group depended on the gender of the patient, on the study ID. Actually, 8 different studies were combined in this analysis. Whether the patient itself had a renal medical history, what age group was this particular patient. If you looked at all 4 of those age covariates, you would have a somewhat complicated model, and you'd like to check whether subgroups based on the the age or sex or the study or the medical history would make a difference as to the effect of the drug on the treatment versus control. And so this notion that you can look at subsets of your data in a clinical trial and then declare that, well, this subset, something very interesting is happening, that's actually kind of a no-no among people that try to monitor these drug trials, because of the worry that they'll just capitalize on something that they happen to see. There's typically the notion that you're supposed to declare in advance exactly which contrasts you're going to be looking at. In a simulation study with the Bayesian shrinkage, though, we found that the shrinkage methodology automatically adjust for this, so that we did a simulation in which you actually looked at 160 separate subgroup by response variable methodology. There were 16 covariate groups here and 10 response events, so there's really 160 things you could look at to declare, wow, I found that older people had a problem with dehydration. So the notion is that if you take the significance from the Bayesian model as opposed to the raw significance just from without the adjustments, you would have 160 things, and to say I'm going to look at the most significant and declare that's my finding would lead to huge biases. But in this simulation, it turned out that that the Bayesian shrinkage does a very nice adjustment for in this case, and that the nominal 90% confidence interval actually did include the true value 86% of the time. So it did a pretty good approach. Another approach is to shrink towards the drug class and events, so that this was an example with longitudinal healthcare data. You could look at 6 antipsychotics and 30 preferred terms for movement disorders. You could compare the disproportionalities with and without a particular Bayesian model that looks at both the events and the individual drug effects. So that here there are the 6 times 30 or 180 raw values without merging them, but if you estimate rows and column effects using a Bayesian model, you get something that looks a lot smoother, as in this one. And finally, we had another project involving web search logs. This was done in conjunction with Microsoft and some other partners. And it's surprising that if you just, we got 50 million people who agreed to have their search logs analyzed just for what they happen to be looking at using various web browsers. And if they searched for a drug at one time and then later on they searched for an adverse event, you might wonder whether they were inherently concerned about an adverse event after starting to take the drug. And so if you try to analyze that data very carefully, we actually found that these search logs could give you about as much information as this big adverse event reporting system, which was quite an interesting finding. So this is, and again, the various Bayesian shrinkage ideas are put into these kinds of analyses. So that's it. Thank you.